We rely on our hearts working 24 hours every day. If something interferes with that, it is a bad thing. Rhythm problems, defibrillators, ablation, and sudden death. Tonight, On Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. Dr. Holm is on a much-deserved vacation tonight. I am Dr. Kelly Evans of the Avera Medical Group Brookings. If you're a musician or even just listen to music, you know how important rhythm is. Life is full of rhythms. The passing of the seasons, cycles of the moon, and of course, the most important rhythm of our lives, our heart rhythm. First, let's take a look at this week's Prairie Doc quiz question. With every minute of delay in CPR and external defibrillation, how much does the death rate increase? A, 1%, B, 10%, C, 25%. Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of Dr. Holm's essays, originally written for this show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We will announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get your answer in. We answer your questions about heart rhythm concerns as they are called in or sent to us via Facebook or email. Call in questions to 1-888-376-6225 or send us an email to the address on the screen. Joining us tonight are Dr. Jonathon Adams and Dr. Paul Olson, both of North Central Heart, a division of the Avera Heart Hospital. Welcome to On Call. Tell us a little bit about your jobs and what you do at North Central Heart.
Well, I've been with North Central Heart since 1991, and we both do a cardiac electrophysiology, so we see people with heart rhythm problems. We see people in the clinic and discuss their issues and go over the options for treatment. We see people in the hospital that have more acute heart rhythm problems, and then we do procedures like implanting pacemakers, defibrillators, do a procedure called ablations also. Great.
And everyone at this table is SDSU alumni back on campus together tonight, so yes, that's a fun factoid. Welcome back. Dr. Adams, tell us a little bit about what you do and the typical problems that you see people come to you with. What symptoms are they having, and how do they end up in your office?
Well, we see people with a variety of symptoms. Depends on what they're having. You know, people, like Dr. Olson was saying, we see people with fast heart rhythms, slow heart rhythms, and it can be anything from dizziness to palpitations, feeling fatigued, sometimes chest pain, shortness of breath. As he said, typically we'll see patients several days per week in clinic. Depending on what they have, they might require a pacemaker if their heart rate's been too fast, maybe some medication or even an ablation procedure.
Mm-hmm. Great. Well, while we're waiting for questions, let's talk about the most common heart rhythm problem, at least that I see in my office, which is atrial fibrillation. Probably a lot of our viewers, if they don't have a family member with it, maybe have a friend or know someone who's had AFib, as it's called. I see it a lot. Not all of those people make it to your office, because often we can treat them with medication and keep symptoms under control. Can you give us the background? What causes atrial fibrillation? What symptoms do people usually present with?
Great question as to what causes atrial fibrillation. I think it varies depending on the patient. You know, the most common people that we see atrial fibrillation are people as they get older. Mm-hmm. There's a statistic that 9% of the population over age 65 will have atrial fibrillation. But I always tell patients it's usually a combination of things. Could be a heart valve problem, but it's often due to long-standing high blood pressure, diabetes, being overweight. I think it's for every 1 unit your body mass index goes up, there's a 4% increase in the risk of atrial fibrillation. Sleep apnea is a big one. Any other sort of heart disease, like if you've had a heart attack, if you've got heart failure. So there's a variety of things that contribute, and we often see people that come in, they've got several of those things, and that's often why they have atrial fibrillation.
Regular excess alcohol use can also contribute. Even regular alcohol use, some studies suggest, 1 or 2 a day can make people more prone to atrial fibrillation. And sedentary lifestyle is another important factor. Studies show that people that are more physically fit will have a significantly lower risk of atrial fibrillation. People, heart healthy eating, keeping the body weight in a normal range seems to lower the risk for atrial fibrillation also.
And in my practice, it's interesting how I would say heterogeneous AFib is. Some people are very symptomatic and end up in the ER with AFib, and some people would never know they have it except on a checkup we hear a rhythm abnormality.
Yeah, what's interesting about that is some people are symptomatic and don't realize they're symptomatic, in the sense that everybody knows about the guy or the patient that shows up in the ER. They sudden onset palpitations, they feel chest pain or shortness of breath, lightheaded. But we'll see people, at least I will see people not infrequently, where they've been feeling kind of fatigued and just kind of don't have quite as much energy, and they've sort of adapted to it, and they've said, well, I'm just getting older, and that's why I feel this way. They go see their doctor and they find that their heart rhythm is irregular. They get an EKG, they find they're in atrial fibrillation, they come and see us. And I will always cardiovert those people, in other words, get their rhythm back to normal just to see, and a lot of times they feel significantly better and they didn't realize it. And so it can be very subtle.
Yeah. And there are times when if the atrial fibrillation is fast enough, we do cardioversion even as an emergent procedure. That's a little bit more unusual, but sometimes it can go very fast.
Yeah, it can. And if it goes fast for a long enough time, it can make the heart weaker also. So there are a number of people that we've seen that will have a cardiomyopathy or congestive heart failure because of being in atrial fibrillation for a long enough time. And then if you restore the normal rhythm, or at least slow the rate way down, then their heart function can improve also.
So what are options? There's a variety of treatments and generally first-line treatment, at least in a general practice, would be to give medications, a pill that people take every day just to keep the heart rhythm from going. It doesn't make the heart rhythm normal. People are still in an irregular rhythm, but it keeps them from going too fast.
So I think of kind of what are the risks of the atrial fibrillation. So one is the risk for blood clot or a stroke, and the other is the risk of making the heart weaker. So the goal with what you're referring to then would be to use medicines to slow the heart rate down to make it less likely that they would have heart weakness and to improve their quality of life, improve their symptoms. And the other medication option, at least that's the main option initially, is to reduce the risk for stroke are the anticoagulants. And some people call them blood thinners. They don't actually thin the blood to make it flow differently, which is kind of a misperception, but they change the blood clotting factors to reduce the risk for stroke. And generally, the risk for stroke kind of, as an average, might be about 5% per year in people with atrial fibrillation. That can vary from 1 to 10 or 12% per year, but the anticoagulants will reduce it down to maybe 1.5% per year or so.
And can you expound on why is the stroke rate increase in AFib? What causes that? Why do people with AFib have that increased risk compared to the average person?
So maybe just use this picture of the heart that shows the electrical signals go from the upper chambers down to the lower chambers, and the atrial fibrillation is where the electrical, you see it? So signals will go very rapidly in the upper chambers. So in a sense, the atria are just kind of quivering or fibrillating like this. And so the blood can pool in different areas. And there's an outpouching in this side that blood can pool in, where blood clots most commonly form. About 90% will form in that area, and then the blood clot can travel out of the atrium, go to the brain and cause a stroke, or go to the arm or leg and cause a problem there too.
So it's a result of blood standing still because of the way the heart rhythm functions there. Yeah. How do we decide who goes on a blood thinner and who doesn't? Because we don't necessarily put everybody on a blood thinner.
Yeah, it's getting to be that most patients are going to end up on blood thinners with some changes in the guidelines and things, but it kind of depends on why you have atrial fibrillation and then how many risk factors you have for stroke. So first of all, we'll almost always get an echocardiogram, look at the structure of your heart, because if someone has, say, a narrow mitral valve, would be the valve between the upper and lower chamber on the left side, they automatically go on Coumadin or warfarin these days. Otherwise, and that would be the minority of patients, otherwise we just evaluate how many clinical risk factors they have for stroke, and then do they have heart failure, they have high blood pressure, diabetes, previous stroke, what is your age, any vascular disease, and then females, that's automatically a strike against you for risk of stroke, I guess. And so if you, historically, it was always if you had 2 risk factors for stroke, we would recommend a blood thinner or an anticoagulant. And if you had no risk factors, we would recommend against it, because the risk of bleeding from the medication would be higher than the risk of stroke if you didn't take the medication. And then if you had one risk factor, it was controversial. You could do whatever you wanted. Some people would use aspirin, some people would do nothing, kind of dependent on the doctor. And now there's going to be, the guidelines are now being updated where they say if you have one risk factor not related to gender, they're favoring anticoagulation, because the bleeding risk on some of the newer anticoagulant medications is quite low. And so that balance between what's your risk of bleeding versus your risk of a stroke has favored anticoagulation.
Right. Yeah, and it gets more difficult if a patient has maybe had something that you're worried more than the average person about their bleeding risk. Maybe they had a GI bleed last year or something like that. Then there's sometimes not necessarily a clear right or wrong answer, and it's a discussion with the patient.
I'll say two things about that. One thing is I'll often see patients who have had bleeding get referred in and they're taking aspirin, thinking that that's really reducing your risk of stroke, and it really doesn't reduce your risk of stroke to any significant degree. And there are medications now, other medications that are available, where the bleeding risk has been shown in some studies to be similar to aspirin, but they are far superior at reducing your risk of stroke. So if you're going to take a medication, you might as well take one that's going to do something to reduce your risk of stroke. Well, I guess I'm going to say three things. Okay. Second thing I would say is that anticoagulation does not eliminate your risk of stroke, so don't feel like it's impossible for you to have a stroke even if you're taking a blood thinner. It just reduces your risk of stroke by about 65 to 70%. Last thing I'll say, the third thing, is that nowadays we actually have a procedure we can do. So if you have a patient with multiple risk factors for stroke, and they have bleeding issues or falls, or you're concerned, because it turns out that the more risk factors you have and the older you get, the more concerned doctors get about giving their patients anticoagulants, and then often the patients at highest risk don't get them. And so we now have a procedure where we put this device in that, and if you can zoom up there, we put this device in the heart, in the area that Dr. Olson was showing you where blood clots are most likely to form. And then you take the anticoagulant for about 6 weeks, and then you can come off, and your risk of stroke has been reduced by a similar degree as to taking the warfarin long term.
Yeah, yeah.
That procedure takes about
That's fairly new. I mean, how long have you been doing that procedure?
We've been doing this for about 2 years.
Yeah,
we've done close to 100 patients, I would say.
Yeah. Great. Well, we've had some questions come in, so let's roll with some questions here. A man from Watertown says, I have mitral valve prolapse and have been on the medication flecainide for 30 years. Is that still the recommended medication for today for this diagnosis? And I wonder if we're missing a little information there.
So the flecainide would be a heart rhythm medication. So it's possible that there was atrial fibrillation, and that is a common medication to use for atrial fibrillation. And it's reasonable if people don't have significant heart weakness or coronary artery disease, and if their EKGs look good, then it's reasonable to take the flecainide for a long time. Flecainide can also be used for early beats in the ventricles or premature ventricular contractions, and it can help with that. Some people with mitral valve prolapse have that rhythm issue too. So it's important to follow it regularly, check EKGs periodically, and make sure that the heart status is satisfactory when using that medication.
Okay. A woman from Sioux Falls asks, what is the difference between atrial fibrillation and paroxysmal atrial tachycardia? That's a little bit of a non-specific term.
Yeah, so I would say, so atrial fibrillation is, I tell patients it's almost like the atrium is having a seizure electrically. You've got complete disorganized, rapid electrical activation of your atrium, your upper chambers of your heart, and the muscle just responds to that by fibrillating, like Dr. Olson was showing. Paroxysmal atrial tachycardia is, by definition, paroxysmal means it comes and goes on its own, and atrial tachycardia implies that you've got some other spot other than the normal spot in your heart that's just firing off on its own spontaneously, and tachycardia means it's going fast. So what you have is a rhythm that's occurring, a rapid heart rhythm that's occurring from a spot other than the normal spot in your heart that generates the heart rhythm, and it comes and goes on its own. It's more focal, I would say. It's more organized, more focal, starts and stops. I would say we read a lot of Holter monitors and other monitors that people wear, and we see those on the majority of that. So whether you feel it or you don't, is kind of about all there is to paroxysmal atrial tachycardia.
Yeah.
Some people can have longer episodes of the atrial tachycardia that can be more bothersome also, and then there can be medications like the flecainate or others, or the ablation procedures that can be used to treat the atrial tachycardia also.
Okay. This is a good one. A man from Tennessee wants to discuss holiday heart in regards to alcohol consumption. What amount of alcohol can someone consume that has had a valve replaced? So I don't know if this person has had that issue or if they've been warned about the issue after a valve replacement, but
think of the holiday heart as a person that's had a substantial amount of alcohol, and then the night or the day afterwards then has gone into atrial fibrillation, which can last hours or a day or two, or be persistent unless it's converted back to normal. It can be many drinks. People have 10, 12, 15 or more drinks. I've had people that say they had 3 or 4 drinks of alcohol in a night, and the next day they went into atrial fibrillation. So it's hard to tell in any one person how much alcohol it would take to cause that.
Right, right.
Yeah.
And I don't know that there's a rule about how much alcohol you can drink after you have a valve replaced. I don't know. That's a usual conversation that probably is had.
I think they just follow the general guidelines.
Yeah.
They say for men, 1 to 2 in a 24-hour period, although I hear some experts say less than daily is healthier than daily. And women, they say 1 in a 24-hour period, although even that amount can make a person more susceptible to atrial fibrillation. So if people have it, have to keep in mind that that might be a contributing factor too.
Sure. Okay. An Aberdeen woman says, sometimes I feel a pitter-patter in the upper chest area. Tends to give me an urge to cough. Once I cough, it stops. Is that a symptom of AFib?
Usually rhythms that stop when you cough are not atrial fibrillation. They're usually something that's involving the middle of the heart, called the AV node. We would fall more in the realm of a rhythm we call SVT, or supraventricular tachycardia. The thing to do there, the valuable thing to do there, is to actually record the rhythm when you're having the symptom. And so that's why we have people wear heart monitors and so forth.
Yeah, it's an interesting story though. It's a pretty classic, what we call a vagal maneuver that might get rid of, and those are more benign heart rhythms.
Yeah, so those rhythms are generally not life-threatening. There's no stroke risk with those, so you don't have to take the anticoagulation or anything like that.
And some people that have that similar sensation will have early beats or premature ventricular beats that make them feel a need to cough too. And those are generally not serious if they aren't extremely frequent too.
Right. Yeah, really the only way to actually get at the diagnosis is to catch it on a rhythm monitor. And I would say the most common thing I see when people actually come in with a complaint of palpitations is those premature ventricular beats that you are talking about. A Rapid City woman asked, do you think if you are taking Effient, do you also need to take 81 milligrams of aspirin? How long do you need to take that after you've had 2 stents? Should you take it for the rest of your life? And this is more of an interventional cardiology question, I guess, but there's I guess, differences in practice between about those things. You care to answer?
So if a person's had stents, it's usually best to take both, 2 blood platelet medicines, the aspirin plus another, Effient and there are others, for 1 year generally. Some studies suggest maybe you can get by with 6 months or less, but if there's been like a heart attack of some type, then usually for at least 1 year. Some people continue them longer term for some benefits, but there's risk for bleeding.
A little over a year ago, I went in for annual physical here in Brookings at the Sanford Clinic. They detected a low heart rate, low enough to alarm them, and what appeared to be an aberration in EKG. 3 weeks ago, I went in for a follow-up EKG. They did one, then informed me they had to have another one. As it turned out, the heart rate was so low that they didn't have enough on the paper. So they, at that time, my heart rate was about 40, but there was another aberration in the beat. And so they examined that and said, you need a pacemaker. It's one of those things where I had no indication whatever, no lightheadedness, no dizziness. In fact, that very morning I had done what was a routine thing for me, go up to the university, hike up the steps to the hyper center. It's 29 steps, 2 at a time. I do that 8 times in a row. Wednesday, or actually Tuesday night while I was in the hospital, I was looking at the monitor, and the beats were around 36, 38 as I was resting. But they would pop right back up if I did anything. But that night then, the nurse informed me that my heart rate on several occasions dropped to 24, and which they found alarming. And I guess that's near hibernation. You know, I guess, technically, from a technical standpoint, what's happened is my upper chamber and lower chamber are not talking to each other. And so I have a 2-lead device, and it will detect the beat instigator in your heart, your AV node, and if the bottom has not activated within a certain number of milliseconds, bang, then it jolts it. So it's constantly monitoring what the upper chamber is doing, and then it will keep the lower chamber, make it keep up with it. It made zero difference in what I was doing before and what I'm doing now. They told me that for a period of 4 to 6 weeks, do not raise this arm over my shoulder so that those leads can knit into the vein. And after that, it is sally forth and do whatever is my normal life. There's no pain associated with it. It's I got this lump here, and but the wound itself is thoroughly healed over, and that's it.
This is your program, and your questions are important to us, so we're going to continue rolling with those. A Rapid City woman asks, I finished that question. A Volga woman asks, if baby aspirin doesn't help prevent a stroke, is there any point in continuing to take it?
So since I'm the one that commented on that,
Yeah.
I guess I will answer that. The answer is that baby aspirin doesn't do very much to reduce your risk of stroke from atrial fibrillation. Right. There are patients that have carotid artery disease and things like that, and that can reduce your risk of stroke for that. So it depends on why you're taking aspirin. I see a lot of people taking aspirin just because it's healthy, and there's actually been some data that shows that that can actually be more harmful than helpful. So if you don't have a good reason to take the aspirin and you have atrial fibrillation and your doctor recommends anticoagulation, then you should take what your doctor recommends. Now, if you've had a stent before, or you've got carotid artery disease or some other vascular disease or some reason to take the aspirin, then you might have to take both.
Yeah, good.
There are many people that don't have heart disease, carotid artery disease, and are just taking aspirin just because, probably aren't benefiting from it. There are studies that are suggesting that people don't have a significant improvement, like doesn't reduce the risk for fatal events, and it does increase the risk for bleeding, anywhere from minor to potentially serious bleeding also. So it's important to discuss with the physician exactly, is it appropriate to take it, or is the risk outweighing the benefits? Yeah,
and some of those studies have been presented on the evening news, such that I'm having conversations a lot with patients about that, which is good. A woman from Yankton asks, are there any situations with atrial fib that you would automatically go to ablation, or when is ablation the preferred treatment?
So you can go directly to ablation for someone with paroxysmal atrial fibrillation these days. So I've done that in the past. You have to keep in mind, Dr. Olson suggested this earlier in the show, is that with atrial fibrillation, you have to keep in mind what is your goal of the treatment. And people need to understand that the goal of ablation for atrial fibrillation, ablation, by the way, means that you're going to injure areas of the heart on purpose to make the rhythm remain normal. The goal of that is purely to improve quality of life and alleviate symptoms. It doesn't get you out of jail with the blood thinner or the anticoagulation. It doesn't save your life. It hasn't been shown to save your life. There's been several trials trying to show that. It's purely based on a symptom basis, so people that are relatively healthy, have symptoms, you don't really want to give them medication. For years and years, you might offer them ablation. You always have to take in consideration the risks versus the potential benefits.
Yeah, Okay. And just a little background, since we haven't really touched on ablation, give us the basics of what you tell people about an ablation procedure. Do they have to stay in the hospital? How long does a procedure take? That kind of thing.
So the ablations are done for several different type of rhythm issues. Atrial fibrillation is one, atrial flutter, which is an organized circuit in the atria, or this supraventricular tachycardia that we're talking about, or the rapid rhythms in the ventricles. Usually it's a one-day procedure. It can take from 1 to a few hours. People are either sedated, or with atrial fibrillation ablations, they're under general anesthetic, so asleep through the procedure. Then they're in bed a few hours afterwards to let the puncture sites heal up. And then usually in a hospital one night, most commonly home the next day. Usually recommend not doing strenuous exertion or heavy lifting for about 5 to 7 days afterwards. And after that, usually pretty much normal activity thereafter.
Okay. A man from Rapid City says, I have atrial fib and my cardiologist prescribed me Eliquis, but I bruise so easily with that medication. Are there any better options?
Well, so it depends on the number of risk factors you have, but if you're qualifying for Eliquis, and like I said, most patients do, you could consider having one of the devices put in these days, or doing something with that, what's called the left atrial appendage. It's the spot in the heart where blood clots are most likely to occur. We do see a lot of bruising. It kind of depends on the extent of the bruising and how much it's bothering the patient to whether they can decide whether a procedure is worth it or not. Eliquis seems to be one of the lower risk devices that I've seen for bleeding among all the blood thinners out there.
Yeah.
Yeah, there are other options. They all do have that risk for bleeding, and it's probably important to be sure if a person's on aspirin, if there's not another reason to take it, to come off of that, to make sure that that's not a contributing factor to the bruising also.
Yeah, good point. A man from T says, I was told I have a condition called left bundle branch blockage. Can you explain this?
Well, I think this is where the picture
Yeah.
might be helpful. So the electrical conduction, as we mentioned before, goes through the pathways through the right bundle branch and the left bundle branch. And people can have, over time, where scar tissue can build up, where the conduction system can just stop functioning as well, where the signals will block in the left bundle branch here. So then they will get through the right bundle branch and then come around to the left side of the heart and just take longer. Many people can have that and have no symptoms or no problems with the heart. Some people, it can potentially cause some weakness of the left ventricle if the conduction delay is significant enough over a long enough period of time.
Okay. And do you need any treatment for a bundle branch block, or often it's kind of an incidental finding, I would say?
Yeah, so I think if I saw someone with a left bundle branch block and it was an incidental finding, I would do some evaluation. I would check and make sure their heart function was normal. Basically, I'd start with an echo because you want to see, is their heart function normal? If it's not, they might need a stress test or an angiogram to evaluate, like, why do they have that left bundle branch block? If it's purely due to aging and the conduction system is just kind of wearing out, if the heart function is normal, you don't really need to do anything about it. If the heart function is abnormal, you can put in a special pacemaker device to help improve that heart function by correcting the conduction delay.
I can show in the picture again, there's a smaller percentage of people that do develop the heart weakness from the left bundle branch block, and if a pacemaker can be placed with a lead on the left side of the heart, and if the left side is contracting in a delayed pattern, pacing then the left side along with the right side can bring both sides in at the same time to improve the heart function. It has a probably 65 to 75% chance of improving the heart function. So people do develop heart weakness and have a left bundle branch block. That's a good option to discuss to try to improve the heart function further,
and
along with medications.
Those are very specific patients, but it's a pretty remarkable result for the right patient.
Yeah, it is. Not everybody with a left bundle branch block has a weak heart, but it's worth it. But I would check,
Sure. A patient from Fort Pierce says, I was on chemotherapy for 10 months and had abdominal radiation for 6 weeks 4 years ago. I'm 72 years old. He's 169 pounds. He does vigorous exercise 4 to 5 days a week for 2 hours, which is excellent work. Will the long-term chemotherapy and radiation have an ultimate effect on my heart? That's a pretty specific question, and I guess he mentions the type of chemotherapy he was on, gemcitabine and 5-FU, that I'm not particularly familiar would have a typical cardiac side effect.
I think that would be unlikely. If the radiation did not involve the heart, then that should be okay.
Yeah.
Yep.
Yeah. Doing great things for his heart with all his exercise, though. That's great. A woman from T says, I have AFib and I'm on Eliquis. I have noticed that I drool on the corners of my mouth at times, and I have heard this may be a sign of tiny strokes. Is this true? Seems unlikely to me.
Yeah, I don't
Exactly.
think
If
it's hard
both
to
sides, that would be less likely. If it was one side, then that would be more suggestive. But it'd be good to have that at least evaluated and see the primary care provider to see if it sounds more concerning or not.
Right, good. We talked a little bit about ablation. A patient from Mitchell says, why do blood clots in fairly large arteries form while the same blood travels through the tiny capillaries in our extremities and don't seem to be an issue? It's kind of a more general question. I guess I would say that it has to do with blood flowing, right?
Exactly,
What does it take for blood to clot?
Yeah, well, when blood flow becomes stagnant, which is what happens in atrial fibrillation, for instance, the atrium stops contracting normally and blood flow becomes stagnant. And you know this, I mean, if you cut yourself and you let it just sit there, the blood will start to clot. And that's what happens when blood flow stops. Now, in normal functioning arteries or capillaries, blood is flowing through those at a consistent rate. And so the blood flow is not stagnant, so it won't start to clot. Now, in arteries that have blockages and so forth, plaque in them, if that plaque ruptures, that triggers a response that starts to form a blood clot.
Right, right. Which is a different issue, generally speaking. Okay. Another question. A woman from Lenox says, I have AFib and my heartbeat is usually in the 70s. Is that too fast?
That's a reasonable heart rate.
That's great.
I think that's a pretty good heart rate for atrial fibrillation. It'd be helpful to be sure it doesn't go excessively fast with physical activity, so checking it with activity with a heart monitor or an exercise test can be helpful there too. But that's a very reasonable heart rate, yes.
Good, pretty normal. A Brookings woman asks, why am I having lightheadedness almost all the time? When I walk, when I wake up. I had quadruple bypass 9 years ago and I have stents. What could be contributing to this? I say this is one of the hardest complaints to sort out, would be dizziness or lightheadedness sometimes.
Yeah, I mean, it could be fast heart rate, slow heart rate, low blood pressure, heart could be weak. She's had stents before, a variety of things. You almost have to record your vital signs, your blood pressure, heart rate, heart rhythm when you're having the symptom.
Could be inner ear issues, vertigo, a lot of other things that are not heart related too can cause lightheadedness and dizziness. So, yes.
Yeah. But sometimes it is really hard to get at the cause of those complaints. A man from Sioux Falls wonders, is there any advantage of using a 5-grain aspirin? You familiar? I'm not sure if I understand that question.
So it would be like 325 milligrams of aspirin as opposed to 81 milligrams of aspirin. And for most people, the 81 milligrams would be sufficient. They used to think the 325 milligrams was more effective for atrial fibrillation, but now found, as we talked about before, that that's probably not helpful in any dose for atrial fibrillation. People have other conditions that they benefit from higher doses of aspirin, arthritis, then that can be more helpful. But 325 milligrams or 5 grains is probably no better and probably has a little higher risk for bleeding than the 81 milligram dose. So that's the most common dose that's used these days.
Sure, yeah, and that's evolved over even the last 5 to 10 years, I would say. Okay. A Sioux Falls man asks, I have one vein that works with a stent. I have had 1 mild heart attack, lung cancer, 1 removed. I have had an irregular heartbeat since my chemo 6 years ago. I've been on a 325 milligram aspirin daily for 5 years. How long is it effective? How long should I take it? What are the limitations and what are the effects of extended use? So we touched a little bit on that. We're not actually sure what type of irregular heartbeat this patient has, or if he has other reasons to be on that dose of aspirin.
Yeah, I mean, there's lots of different causes for why someone's heart rhythm could be irregular. You could have skipping beats from the upper chamber, lower chamber. You could have atrial fibrillation, atrial flutter, variety of things. So it's really hard to say or answer that question specifically without knowing a little bit more about exactly what's going on.
Right.
Yeah, so it can be helpful then to do the heart monitors, like there's the Holter 24 or 48-hour monitors, there's 2-week patch monitors that can be used, there's 30-day monitors, so it's helpful to see what the rhythm is with the irregularity to know is it concerning or not? Is it something that might be treated easily, or is it just something that's not of all concern, and maybe reassurance is the most appropriate strategy for that too.
Sure. Okay. Patient from Sioux Falls says, I want to avoid taking a low-dose statin as long as possible. My cardiologist told me my LDL needed to be as low as 70 to be safe. I think that is almost impossible to attain without taking a medication. What level of LDL can I have to be safe and not need a low-dose statin? Another place we're missing some information here, and there's been changing guidelines about statin usage and cholesterol too, so it's a little bit complex. I assume if he's seeing a cardiologist, he may have some coronary disease, so yeah. Mm-hmm.
Yeah, and the studies suggest the lower the LDL goes, the lower the risk for further events like heart attacks or strokes. So they used to say under 100 is good. Now they're finding that people do better if it's under 70. Some studies suggest people do better if it's under 50. If a person has had heart disease, coronary artery disease, it's almost always appropriate to be on a statin, is what the studies are showing, in the guidelines, and experts would indicate that's very appropriate. Lowering the risk for fatal events. So the risks of the statin are far outweighed in most people in that situation by the benefits of taking the statin.
Right. It's a little more controversial in someone who doesn't have any coronary or vascular disease, but if you do, it's a pretty unanimous recommendation. Okay. A woman from Wessington Springs says, I'm 84 and had a stroke about 3 years ago and had to take 325 milligrams of aspirin. I'm still taking it, and should I be taking it? And so,
it sounds like it depends on what the cause of the stroke was. Again, if it's carotid artery disease, you're probably on aspirin indefinitely. If they never found the cause of the stroke, rhythm monitoring would be very appropriate, considering she's in her 80s, because, like I said, it's very common to see atrial fibrillation. Matter of fact, we see patients not infrequently that have had a stroke, they don't know why. We'll put a monitor on just to look for arrhythmias that might have a risk of stroke. And if we don't see an arrhythmia on that, we'll implant a monitor. And here's an example of one right here. Like something like this, where you can just inject that under the skin, and you can see atrial fibrillation show up several months later that the patient was completely unaware of, placing them at risk for another stroke, and obviously you would put them on an anticoagulant at that point. It's thought to be about 20 or 30% of patients that have had a stroke and don't know why might have atrial fibrillation.
Yeah, okay. A Sioux Falls woman asks, I have hypertrophic cardiomyopathy and had AFib for 25 years. I was interested in the small device that the doctors were showing. I assume she means the Watchman device. Could I be a candidate for a device like that with hypertrophic cardiomyopathy?
I'm thinking defibrillator.
Okay.
You think?
Yeah.
I'm thinking
not sure.
The Watchman could be considered for the indications Dr. Adams is referring to. If there's bleeding problems on the anticoagulants, then a person could be considered for that. People with a hypertrophic cardiomyopathy in some situations can be at higher risk for a more serious rapid rhythm in the ventricles. That's a very smaller subset of those people, but in some situations it can be appropriate to discuss implantation of a defibrillator, which can treat a rapid rhythm in the ventricles if that does come on.
All right. A Huron woman says, my EKG showed a right bundle branch block. Is there a different diagnosis and treatment than what you discussed for the left bundle branch block?
Right bundle branch block is generally benign, doesn't really cause heart failure, weakening heart. Very common. You seem to see it more common than left bundle branch block. Yeah, I don't think you have to do anything specifically for that.
Yeah.
No.
Usually an incidental finding. A Highmore man says that he has a son with AFib and has a defibrillator. What are the risks of having an ablation performed? So let's, I guess, talk about that. What are the general risks that you tell patients if you're considering the ablation procedure?
So the risks of an atrial fibrillation ablation, I tell people, well, there's a registry that people enter data into. The risks are generally about 4.5%. That I tell people, listen, we can damage anything that we touch. So anything from bleeding in the groin, damage to the vein in your leg. You could perforate the heart. You could injure the conduction system. You can have narrowing of those pulmonary veins that we try to ablate. There's about a 1 in 1,000 risk of a stroke or a heart attack or even death or needing heart surgery. Might need a blood transfusion. There's this specific risk to atrial fibrillation ablation called risk to your esophagus, because if you injure the esophagus, which is your food tube, that can heal together with your atrium, and that's very serious, fortunately very rare, but it's worth knowing about if you're going to have the procedure done. But if you add it all up, all risks together is 4 to 5%. Risk varies obviously based on the patient and how old you are and how many other problems you have and things. But generally it's pretty safe. The real serious risks like stroke, heart attack, needing surgery, esophageal injury, those are all less than 0.5%.
And we're talking about ablation for atrial fibrillation specifically. You do that procedure for other heart rhythm problems, and generally AFib is the most difficult ablation procedure you do. Is that true, not true, or the risks higher with AFib compared to some of the other?
I would say not true.
Not true, okay.
The harder ablations, I think the harder ablations tend to be, it depends on where you're trying to ablate, and the harder ablations tend to be like ventricular tachycardia ablations, because those rhythms, a lot of times we can put a patient into a rhythm and you can study it and those kinds of things because they remain stable, the blood pressure remains stable. A lot of times you're trying to ablate ventricular tachycardia, especially in someone who's never had a heart attack or anything before, the blood pressure drops and you can't really study it and you're trying to figure out where to ablate. Other things come into play with ablation, like I said, exactly where you're trying to ablate. I've ablated arrhythmias at the base of the aorta, like right on the cusps of the aortic valve, where you're very close to coronary arteries and the risks are significant that you could damage a coronary artery. Other things, like if you're ablating, there's little muscles that hold the valves in place, and those muscles are moving, they're kind of thick, the patient's breathing, the heart is moving. Just to try to get your catheter stable in position on those can be quite challenging. Sometimes people will even ablate arrhythmias that come from the outside of the heart, so you have to get a catheter into that space without causing a problem. So those can be quite challenging. So I'd say atrial fibrillation, believe it or not, these days has become, it's also become a little bit, I don't want to say easier, but less difficult because we do so much of it. It's the most common ablation that I do, because a lot of people have it.
Right. Okay, we've had some more questions come in. An Aberdeen man asks, are the doctors prescribing the usage of much low-dose amiodarone? So amiodarone would be one of those rhythm control medications we were talking about.
We do use it. We've used it many times over many years. It's an old medication in a smaller subset of people. People that have significant heart weakness, heart disease, are better candidates for the amiodarone because they tend to have more potential adverse effects from some of the other medications. The amiodarone is something that has to be monitored closely because it can cause other adverse effects. It can cause lung toxicity in about 1 to 1.5% of people per year. It can cause abnormal thyroid function in about 10 to 12% of people, abnormal liver function, others like issues like balance problems or tremors or stomach or GI issues or changes in the cornea of the eye. So we do use it often, but we want to make sure that the rhythm is bothersome enough, like for atrial fibrillation or rapid rhythms in the ventricles that are more serious, or frequent early beats or premature beats in the ventricles that may have caused heart weakness, to where it warrants the use of a medication that has a bit of risk. Usually if we use it and we stop it, the side effects will resolve. So it's general, if the rhythm is concerning enough, it is worthwhile to treat it, but it does require regular follow-up to be sure that it's not causing adverse effects, and if they occur, then to either lower the dose or stop it.
Another thing to keep in mind is, like, we'll choose amiodarone in people that may not have many other options. So there's only so many antiarrhythmic medications that we have, and if your heart is thickened or it's weakened, you've had a previous heart attack, your kidney function is not very good, amiodarone may be the only option for you, and so that's often how you end up with amiodarone. Or it's also a very effective antiarrhythmic medication, so if the other ones aren't working, you might try that.
Okay. A Sioux Falls woman explains, I had a heart attack in 2013 and got 3 stents. I got 5 stents in 2014. I had an aortic valve replaced in 2016 and a defibrillator placed in March of 2016. I had 3 aneurysms repaired in 2016. This woman's been through a lot. I had a superior mesenteric angiogram and stent in my small intestine, and I guess there's not a question there. It brings up an issue, though, that I think is worthwhile discussion. What's the difference between an internal defibrillator and a pacemaker? They kind of look the same, right?
Yeah, it is.
So a pacemaker is a device used to treat slow heart rhythms, and we could just show like models. The pacemaker is smaller, about this size, and the defibrillator is a bit larger. The pacemaker primarily is for the slow rhythms that can be causing dizzy spells, shortness of breath, passing out spells. The defibrillator, the typical defibrillator has leads that go in the heart, will treat slow rhythms also, but it can also treat rapid rhythms in the ventricles that can potentially be life-threatening. And then both devices can accommodate the other type of pacing system where we can have a lead on the left side to pace the heart from both sides to try to improve the heart function. There is another type of defibrillator Dr. Adams has.
So there's actually another type of defibrillator, another type of pacemaker. So this defibrillator here, so if you just hold them up, let me give you some examples here.
30 seconds left in the program.
All right. So this is a traditional defibrillator. This is a subcutaneous defibrillator. This actually goes underneath your arm and is implanted entirely outside the chest, so it can offer you protection from rapid rhythms without having to be inside your chest. It's not generally used as a pacemaker. Now this here, I'll show you, this is a new thing. This is a pacemaker, and this is like a little pod that gets implanted directly into your heart, and it's a single chamber pacemaker, obviously. But this is kind of where things are going with devices these days. They're all getting smaller and less invasive.
Great example of developing technology
exactly.
there.
So pacemaker, slow rhythms, defibrillator, fast rhythms, defibrillators work also as pacemakers.
We can touch more on that in the after hours discussion, which we have plenty of questions for. And now for the winner of tonight's Prairie Doc quiz question. With every minute of delay in CPR and external defibrillation, how much does the death rate increase? A, 1%, B, 10%, C, 25%. The answer is B. The death rate increases by 10%. It's so important to start treatment as soon as possible in heart events. It was Fred Kopp who answered the question correctly. Thank you, Fred, for participating, and a book will be in the mail to you soon. We'll be right back after this.
Extra, extra, read the Prairie Doc Perspectives weekly essay in your local newspaper. Over 55 newspapers across the state of South Dakota include essays written by Dr. Rick Holm covering a variety of medical and health-related topics. Ask your local paper if they print Prairie Doc Perspectives.
My first experience with cardiopulmonary resuscitation, or CPR, was during the summer of 1969. I was an orderly in a Minneapolis intensive care unit, or ICU, when my patient stopped breathing. I called for help and provided mouth-to-mouth breathing and chest massage until the team arrived. Later, the doctor told me I saved the patient's life, further convincing me that medicine was my life's purpose. Cardiopulmonary resuscitation is the act of rhythmically pushing on the chest and breathing into the mouth of a person whose heartbeat and breathing had ceased. CPR can result in enough circulation to keep the victim and brain alive until spontaneous circulation and breathing resumes. In 1740, the French described how mouth-to-mouth breathing sometimes saved drowned people, and started in the early 1900s, mouth-to-mouth breaths have been given to bring lifeless newborns around. In the mid-1950s, two anesthesiologists, Dr. Elam and Dr. Safar, with the Red Cross's help, began promoting mouth-to-mouth resuscitation for adults discovered in cardiac arrest. In 1960, chest compressions were proven valuable in preserving circulation, especially to the brain, and even more important to survival than artificial breathing. In fact, for patients having out-of-hospital cardiac arrest, it's now recommended going without artificial breathing while giving 3 to 4 inch deep rapid chest compressions at 100 to 120 per minute. In 1947, a Cleveland surgeon used an internal or open chest heart shocking device or defibrillator to save a 14-year-old boy. And in 1955, Boston cardiologist Paul Zoll developed the now popular external on-the-skin defibrillator. Studies show that the defibrillator is even more important than chest compression. With available automated external defibrillators, or AEDs, and people with the courage and initiative to use the AED device, start chest compressions, and call 911, we have even better outcomes. Out-of-hospital successful survival after CPR is about 10%, but increases to 35% when the arrest is witnessed and early defibrillation happens. The sad news is that more than 50% of those who could benefit will not have early defibrillation because bystanders are afraid they might do something wrong. The big mistake is not to try, even if untrained. Simple first-level CPR courses are available in every community and through the internet for anyone interested. AED devices are popping up in almost every community gathering area. Please notice where they are placed. Trust me, if someone has a cardiac arrest and you try to help, you might just save a life.
Apologies for the commotion earlier in the show. We had a crew member collapse and that person is just fine now. A big thank you to our guests, Dr. Paul Olson and Dr. Jonathon Adams, for volunteering to travel to our studio in Yeager Hall on the campus of South Dakota State University. There were many great questions we were not able to get to during our broadcast time. We will continue to answer those questions on our Facebook page following the program tonight. Go to the Prairie Doc Facebook page. We'll be there shortly after the broadcast ends. Flu season is in full swing now. Last week there were 108 new cases in South Dakota and there has already been one death this season. While it started more slowly than last year's flu season, it has begun to climb. It isn't too late to get your flu shot. It's important not just for you, but to protect those around you. That does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
And starve of fever? Or is it the other way around? There's a treasure trove of lore that surrounds our health. Myths in medicine, Dr. Google, and alternatives, good or bad. Next time, On Call with the Prairie Doc.
For more than a decade, Dr. Holm, in his role as the Prairie Doc, has emerged as a leader of healthcare education and communication in South Dakota and across the country. Every week, Dr. Holm and other medical professionals volunteer many hours to share science-based truth about healthcare on public television, on the radio, in our newspapers, and online. And best of all, everyone has free, easy access to the entire Prairie Doc library. Hi, I'm Jennifer May of Rapid City. As a board member of the Healing Words Foundation, I ask you to consider making a donation. Please help us continue this important work. Go to prairiedoc.org and make a donation today. Thank you.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
and by
South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota,
and with the ongoing support of these individuals and institutions.
Brookings Health System,
Ophthalmology Limited,
American Academy of Family Physicians Foundation, and the South Dakota Academy of Family Physicians.
Avera Heart Hospital.
Dakota Allergy and Asthma.
CoBank.
Fishback Financial Corporation.
Vance Thompson Vision.
Urology Specialists.
Brown Clinic.
Black Hills Medical Society.
Aberdeen District Medical Society.
3rd District Medical Society.
7th District Medical Society.
Dakota Bank.
Orthopedic Institute.
Physicians Care Sanford Clinic Community Service Committee.
Aberdeen Asthma and Allergy.
And Swiftel Communications.